Hello and welcome to session 2 of day 2 of the 4th annual Completed Life Conference, entitled Lives in a Crossroad. Is a person free to seek medical treatment that is not yet legal in their home state? It's such an honor to welcome Dr. Diana Barnard, MD, and Thaddeus Pope, JD, PhD, HECC, to our virtual stage. Thank you both so much for being here. So, hi, Diana. If I may, let's begin with you. You are a practitioner of medical aid in dying in Vermont, and you teach other providers about MAiD. People are dying differently than they did 100, 200 years ago. Why do we need medical aid in dying?
That's a great question, and thank you. It's really a great opportunity to be here. I would say that, first of all, just to begin with a very brief description of what medical aid in dying is, which is a practice that allows a person who is an adult and is capable and is living with a terminal illness and a life expectancy of less than 6 months to go through a thoughtful process and request of a prescriber medication that they may choose to self-ingest in order to hasten their death when their suffering has become unbearable. And one of the reasons why we need medical aid in dying, and as I like to say, lots of other tools in our toolbox to manage the needs of terminally ill people, is that dying does look so different than it did 100 or 200 years ago, because we have many less sudden deaths, and modern medicine has made some great strides in helping us all live longer. We're saved from accidents by seatbelts. We prevent heart attacks or strokes with medications and interventions. New cancer therapies help extend life for a long period of time, and those things are all wonderful. And yet, life, as we say, it is still a terminal illness. And eventually, we all near the end of life. And what happens now is that so many people are living longer that the final phase of their life is more complicated. They have a higher burden of illness. They have higher care needs. Their needs are so great. And for some people, that natural process and needing a lot of support and getting that support works just fine. But for many other people, that doesn't work very well. And there are people who don't want their life extended in those final days and weeks with a great deal of troubles being independent and managing their own affairs. And because of that, medical aid in dying offers one tool to help address the suffering that those people feel.
Just to make a little bit of, I guess, a math point, which is overwhelmingly, right, very, very few people use medical aid in dying, right? So like 99% of everybody who dies, they can withhold or withdraw life-sustaining treatment, use VSED, use palliative sedation, or just, use hospice. And so it's far less than 1% of all the people that die in the states that allow medical aid in dying, that use medical aid in dying. So the other options, most people find those sufficient to address whatever end of life suffering they have. And I just wanted to make a little bit more of a mathematically precise point. So it's very, very few people that die using medical aid in dying, even in the states where it's authorized.
I think that's such an important point. And one of the other things that's so important to keep in mind is that we can't always predict or lay out an exact plan for how our life will come to an end. But many people have a clear idea of what they do want and what they don't want. And so one of the themes here is having a lot of options available, because we never quite know what's going to happen. And it's great to have a plan A, but honestly, as a palliative medicine provider, I am very interested in having a plan B and C and D so that we can manage unexpected occurrences and still maintain a reasonable amount of comfort and address the suffering that each individual patient is feeling.
Fantastic, and thank you for the introduction to medical aid in dying. And I love this idea of an end of life toolkit. what might you suggest as the possible options available within that toolkit?
Well, I think the most important way to start that toolkit is with a well-informed patient with a team of providers that can communicate with them in an honest and supportive way. And one of the themes that I'm sure we'll revisit today is just the importance of people really understanding what is their illness, what are their options, and what are the chances that those options are really going to help. Unfortunately, I see a lot of situations where people haven't really been well informed about the realities of their diagnosis and what the end might look like. I would say, 98% plus of my patients will tell me very simply, I want to live as long as possible, as well as possible, and I would like to die peacefully and quickly. And if you think about it, those are not complicated ideas. They seem reasonable, and yet achieving those things on the ground is much more complicated than you might imagine.
Yeah, I would echo all of that. I mean, and so the question of, if you frame it, I think as the way that you did, which tool is the appropriate tool to take out of the toolbox, is not a question that's purely a question of clinical or scientific expertise. It's a value-laden question, right? It depends on the patient's preferences, goals, and values. And so that's why it really needs to be a product of shared decision-making between the clinician using her expertise, but also the patient bringing her preferences, goals, and values to the table. And so you can, so I don't think there's any right sequence. Like first you always, use this tool for this situation, or this tool for this situation. I think it's going to depend upon the particular patient and what her situation is and what she wants to accomplish.
And thank you for bringing that up. This idea of shared decision making seems so crucial to highlight, because that's establishing a one-on-one patient between the clinician, you, Diana, and the patient. So to kind of zoom out a little bit, and Thaddeus, would you help us think through kind of a roadmap of where medical aid in dying is legal, as medical aid in dying is one of those tools in a broader toolbox context? Where is it legal now? What are some differences throughout the US? I know it's legal in some states, less legal in others. There's different requirements for eligibility. Help us understand the big picture.
Yeah, so in the US, it's legal in 11 jurisdictions. So Hawaii, California, New Mexico, Colorado, Washington, Oregon, Washington, D.C., New Jersey, Vermont, and Maine. Hope I did that right. I hope that's 11, but
Montana.
Montana, right? I always forget Montana. So I was going left to right there. Okay. But what you raised is a very important point, which is it's not binary anymore. I think it used to be, right? Does your state authorize medical aid in dying, or does it not? And I don't think it's really appropriate to look at it in that sort of binary fashion anymore, because there's a lot more variability and diversity than there used to be. So let me just give you a couple examples. One is who is allowed to prescribe medical aid in dying. In most states, it's still a physician, an MD or DO. But now in Washington, in Hawaii, in New Mexico, it can also be an APRN and sometimes a physician assistant. And that's important, especially in a state like New Mexico, which is rural, right? Because there isn't always physician availability. So it's not just have we authorized it legally, but have we authorized it in a way that's actually going to make it accessible to big parts of the population. And then a big way in which there's now more diversity than there used to be is in terms of waiting periods. So traditionally, and I think Vermont still follows this model, there's a 15-day waiting period. But what the evidence shows, and there's actually pretty good evidence on this, is a lot of patients don't start exploring medical aid in dying until late in their illness, which means practically they're not going to make it 15 days to make that second request. So California, Hawaii, Oregon have shortened the waiting period to sometimes to zero, meaning the entire waiting period can be waived if the clinician certifies that the patient can't last the waiting period, or at least down to 48 hours. So that's another big way in which there's now more diversity. And then of course, the third example, which is the one we're going to dive into, is residency. So Vermont and Oregon dropped the residency requirements, and that's currently now a big question in New Jersey.
So turning to Vermont, earlier this year in 2023, Vermont's governor removed its residency requirement for medical aid in dying. And this was 2 months after Linda Bluestein won her lawsuit of Bluestein v. Scott. And Linda was a true pioneer. She's a Connecticut resident who sued Vermont in order to access MAiD for herself. And so what are the practical implications of the elimination of a state's residency requirement? How did this process unfold and impact your practice, Diana?
Well, it's complicated and it's still unfolding. I would say the most important thing is that we've come to realize that limiting your access to medical care by the state that you happen to be a resident of is not okay. It's not constitutional. And in Vermont, we recognize that reality, and we did a pretty quick job of fixing or removing that restriction, which really was inappropriate. However, there are a lot of practical implications. So I work on the western side of Vermont, so I care for patients in Vermont, and I also care for a lot of patients just across the lake in New York. So they are close by, a car ride away. And for those individuals to access medical aid in dying in Vermont is still reasonably doable. So they can come and they can visit with me. However, one of the things about our law is that in order to be protected from the law, all of the steps need to happen in Vermont. So that means the first request, the second request, which is at least 15 days later, and then the actual day of ingestion if the patient chooses to move forward. All of that needs to happen in Vermont. And so what we're realizing is if you're traveling from farther away, like Connecticut or Massachusetts, then there are some real practical implications about where, for example, you're going to stay when you're making your request or you're ingesting, and how you're going to be able to transfer your hospice care. So many of the patients that I'm seeing are already enrolled in hospice in their home state. And because I believe hospice is the gold standard and a really important framework to care for patients who are dying, regardless of how they're dying, we need to make sure that we can organize that. And then the most important issue is just traveling. So traveling when you are living with a terminal illness is difficult, and people have symptoms and they're tired, and quite frankly their time is very precious. So how they spend each day really is up to them, and for people to have to take a chunk of that time and energy and dedicating it to accessing this one option which they want to have can be a real challenge.
Thank you so much for outlining that for us, Diana. And I'm curious, what would be you mentioned 3 visits, one to define eligibility, a second to conclude the 15-day waiting period, and then a third follow-up visit to certify that when the patient is ready to receive the medication, that you do a third and final visit. I'm wondering what's kind of the minimum and maximum that you've seen with patients. So for example, if someone travels from far away, say Florida, and they arrive in Vermont for 3 weeks and are eligible, do you think all of those steps could be completed in that time frame?
So just one point of clarification, that I don't always see the person for a third visit, although I do touch base with them either by telephone or with their hospice team to assure that their symptoms are well managed and to make sure that if they're moving forward with the procedure, that everything goes smoothly. So that's just important to keep in mind. But as Thad mentioned earlier, the truth is that And as I said earlier, people want to live as long as possible and as well as possible. So the truth is, people do wait until late in their illness to make the request. When it's clear now that they're moving from living to dying, then suddenly their priorities are changing and they're like, oh yeah, now I want to have some say in how I die. And for those people that want to consider medical aid in dying, there's some planning that's involved. And so there are different ways that it might look like. For example, I think the easiest way, or the one that makes the most sense to people, is if they already have a connection to Vermont. Let's say they have a second home, or they have a family member or a good friend who lives here, and they decide they want to come and spend their final weeks here. That could certainly happen, where they would come for the entire process. But if you think about it, many of these people are also focused on life closure and saying goodbye to important people. And so many of these people still have important things they want to do at home. And so this issue of travel back and forth becomes necessary and practical for people. And figuring out that very narrow window of when are they too busy living to worry about what dying is going to look like, and when are they starting to put their dying plan into place, that's where I think we have learned, as Thad was mentioning, that this 15-day waiting period, which initially was put in place to be a safeguard to make sure that people are thinking carefully and have time to evaluate all their other options, has actually also become a barrier. Because it is keeping many people who wish they could consider this option, and it's eliminating it because they're too sick. So it's a challenge for me when I get a call from someone who's considering coming here, and I'm talking to them about what's going on with their illness, and whether or not it makes sense for them to give a certain amount of time and energy to this process, or are we in a situation where they have other priorities?
Yeah, there's two things that made me think of. Is first, I think it actually used to be a 17-day waiting period in Vermont, right? Because the 15-day waiting period ran consecutively to the 48-hour waiting period between the writing and the filling of the prescription. So actually, Vermont had after the old Hawaii requirement, had the second highest waiting period in the country. But now it's, by comparison to many other states, it's still pretty high. But the other thing is, on the residency requirement, what you're saying is, if you distinguish two types of patients: the types that would come to Vermont but still want to live as much of their life back in their home as they can, and only come to Vermont at the last possible moment. But then there's other patients who would come, I guess, to Vermont for the quote rest of their life, and they could already do that before the residency requirement, because they would basically become Vermont residents. Mm-hmm. I mean, they're going to relocate effectively permanently. So for at least for those patients, the residency requirement really didn't make a very big difference, because they were already going to make that permanent move and establish residency. It's the people that want to, I guess I meant to ask this as a question, that it's only for these people that aren't going to come for the last 2 or 3 months of their life, that want to minimize the time that they need to spend in Oregon. It's those patients for whom the removal of the residency requirement seems comparatively more important. Does that sound right?
Yeah, yes, I think so. I mean, it is true that establishing residency could be relatively straightforward. And I guess I feel the need to say, sort of in defense of our law, or as an explanation about our law, when we were the first state to pass the law through a legislative process, and it was a new concept. And so because Oregon had passed their law and had years of really robust and good data, we decided to pattern our law after Oregon's law, because we had a lot of data to show that some of the repeated claims from opponents that have not come to pass, to really show that that was true. Now, one thing I've learned over the course of my life, and certainly in medicine, is things are constantly changing and moving forward. So here we are. We established our law, but meanwhile, things are changing and moving forward. And some of the other states that have now passed their laws are realizing that some of the safeguards that we have in place are really overly burdensome, and they're barriers, and they're not clinically relevant or necessary, and trying to trust that a person who is dying, who is very clear about their own personal values and for whom having this option is really important, that we should really trust that. And how long do we make them think about it, and how many times do we require of them to ask of us to have the option?
That comment reminds me of something. I believe that in the initial version in 2013, that Vermont was actually going to sunset all of those requirements, and so it would be authorized, but then all the stuff about the waiting periods, all that stuff would get sunsetted out, right? It was only there for like a probationary period. I think I'm remembering that right. And then if that were true, then and that really happened, I think they repealed the sunset. So then obviously all the requirements stayed in. But I guess what I hear you saying perhaps is that we have all these extra rules that were legislated, but now, at least from the perspective of clinical practice, seem a little bit burdensome and onerous for the patients. And maybe it would be better to leave this to the discretion and professional judgment of the licensed healthcare professionals, rather than to legislate all the minutia of all the rules.
Yes, exactly. I think you're right that, we, again, going through a legislative process, it's kind of ironic to have a law about practice of medicine, right? Let's just sort of admit that's complicated, and it's the intersection of two very different things. And in getting the law passed, as I've learned, I've been told it's a bit like making sausage, right? You look at the final product, but a lot of things happen along the way that aren't necessarily in your control. And so we had a legislator with a strong, let's just say, libertarian kind of philosophy, who really wanted to advocate for that sunset being in place. But at the same time, because it was still early, we were the third state where it became legal, that we were worried that having that in place would open us up to the potential for repealing the whole law. And so a political decision was made that we needed to address that dilemma. Although with the benefit of hindsight, I now look back to those days and say,
So just wondering, whether this residency removal is perhaps more supportive to patients who live directly on the border with Vermont, whether on the New York side, the New Hampshire side, or within driving distance from another state like Connecticut or maybe Maine, versus from a state where they would have to potentially fly to Vermont in order to access the law. Would you say that could be an important distinction for people who live, a plane ride away from Vermont? What would you suggest?
Well, I do think that the way that you travel and how long it takes you to travel is certainly an extra burden that people need to consider. So it is a lot easier for people to think about getting in a car and controlling that travel than for people who have to get on a plane. Although I have seen people who get on a plane. Remember, Thad earlier was reminding us how important it is to remember that every patient, every family holds different values, and that is okay. And we want to support that. And for some people, they would never want to consider medical aid in dying. I would challenge or add that many people just don't know, because you don't know until you're in the midst of your terminal illness. And some people have a very clear idea of what they want, and they will do whatever is necessary to get what they want, even if it means some heavy burden. But practically speaking, it is really important. I mean, I am an advocate for medical aid in dying, but I am a bigger advocate for people having a peaceful, best possible end of life experience. And that means a lot of compromise, dealing with unexpected things, having to make last minute decisions, and a lot of things that are really challenging in the setting of a serious illness that's zapping you of your energy and when time is precious.
The one thing about your question that is, I think, tricky, which is, on the one hand, it's obviously easier to drive 4 miles across the New Hampshire border, or as opposed to fly from Miami. On the other hand, that also is perhaps risky, because then you'd think, well, why do I need to relocate to Vermont? I live right over there, right? It's only 4 miles away. And I think, and me may be getting into this, but then you think I'll just stay where I am, right? I don't need to establish Vermont residency, and they may think I also don't need to really do this, meaning all the steps of the process in Vermont, and that is potentially. I'm not saying it's likely, but it's potentially legally risky, at least for the family of the patient.
So that's a great point, and I'm glad you brought that up. Could you explain for our audience what that risk implies?
Well, here's I think the way to say it is in the 11 states that we mentioned, medical aid in dying is authorized. In the other 45 jurisdictions, it's not just that it's not authorized, like it's like a neutral, right? It's actually criminally prohibited. Not specifically, not like medical aid in dying, but there's a general, since like the 1800s, there's been a general criminal prohibition of assisted suicide, where one person cannot help a second person, cause their death. Well, that's exactly what is happening, right? Diana, she's helping them by giving them the prescription of the DDMA-PH that they're going to use to cause their death. So it fits squarely in the definition of assisted suicide. So when you do it, the same thing that you do in Vermont, if you did that thing in New York, it's a crime, right? The same exact conduct. Now, the clinician is not at any risk because she's still doing everything that she does in Vermont, where it's perfectly legal. But the family is assisting the patient. Now, obviously not by writing the prescription, Diana is doing that, but they are assisting the patient by perhaps driving them, right? Putting them in the car, doing the driving to Vermont, doing the driving back. They are assisting the patient perhaps by mixing the because the medications are powder and they need to be mixed with liquid. Right? So there's various tasks that are physical tasks that the family is going to do that would constitute the crime of assisted suicide in any of the jurisdictions. So if you go to Vermont and then take those medications back to a non-MAiD state, that it exposes the family to the risks of criminal prosecution in that other state. There's other risks too, but I mean, we don't need to go, but that's the basic takeaway thing, which is why I think Diana mentioned earlier, the recommendation, not just by her, but by Patient Choices Vermont, and also all the relevant organizations in Oregon say the same thing, which is, yeah, you can come to Oregon from another state, but don't take the medications back to the other state, stay here. And it's for the reasons I just mentioned, because if you take them back to the other state, you're exposing people to various legal risks.
Would you mind walking me through the process of a person applying for MAiD and what that process entails?
Well, for me, when I'm sitting with someone and they're telling me that they're interested in this, I listen and I ask why. I ask them to tell me more, to really understand what does the patient understand about their illness and about their treatment options, and what has their experience been with their illness. For many people, exploring a previous death experience is really important and a primary driver for why they're interested in exploring medical aid in dying. I think it's important to acknowledge that there are many people who die in our country who do not die well. And we have a lot of evidence that shows that if you have witnessed or been a part of caring for someone who does not die well, that is a kind of trauma. And that experience does not leave you. And so you hold on to that, and people worry about what their own experience will be. So I really want to understand people's previous experience. I definitely want to understand what they're most worried about. And, it's interesting that here I am with a doctor and these big degrees, and we have Thad with all of his degrees, and we're talking about all this high level stuff. But I'm telling you, when you're sitting in front of a patient and their family, they know who they are and they know what's right for them and they know what's not right for them. And so they sometimes will say to me, this is just what I want. Sometimes my questions seem like a lot to have to answer, but it is important that people are really well informed, and they aren't always well informed. And for some people, remembering, for example, if someone is living with an advanced cancer and they've been getting active treatment, but they're feeling awful, and when they get their treatment, they end up in the hospital and their quality of life is really poor, I remind them that they can consider stopping that active cancer treatment, that there are other things that have been started to help them live longer that may reach a point where they no longer help them. So making sure that people understand they can stop treatments that are not helping. They can say no to certain medical interventions like CPR or being on a ventilator, or even going to the hospital when those interventions no longer help them. So I really want to make sure that people understand all of their options. Many people are afraid of or misinformed about hospice and what it does. And to be honest, what it doesn't do. And what I mean by that both is that hospice is a program of care that is designed to address multidimensional suffering. And I believe anybody who's dying should be on hospice. And it's also true that in addition to having a nurse who checks in on you and a social worker who can help manage some of these difficult decisions and support your family, and your home health aide that can help you with a shower, and a volunteer who can companion you for a few hours a week, there are many hours in a day and many hours in a week where you may need caregiving. And the truth is, we do not have medical resources that pay for that caregiving. And so the caregiving needs, which many people on hospice need, falls either to privately paid caregivers, if people have financial resources and are blessed to be able to find caregivers, or family. And family situations are more complicated these days, right? We're not all living in the same household with grandma and a couple of aunts and uncles and many people to pitch in. People are living far away from one another, and there simply aren't those caregiving resources. Nonetheless, when I'm talking to people, I want to make sure they understand that caregiving can be a blessing, that having a natural death and letting your body slow down and having time to do some life review and visit with people and say your goodbyes and talk about what your wishes are for what happens after you die, all of those things are really important. And I want to make sure that people are exploring all of that. And it's also true that there are still some unexpected things that may come up. So I may talk to somebody who's very interested in having the option of medical aid in dying, but they may have a sudden medical event that leads to their body shutting down before they can actually do the process. And again, I also talk to people who would never want to even consider medical aid in dying, and that's off the table. But it really is a deep exploration of all of their options and helping support people in accepting that life is coming to an end. I think in our society, we have sort of forgotten that life and death is part of a cycle and it happens to all of us. But we don't see it and we don't talk about it in our churches, in our neighborhood potlucks, at home. We've become so successful at extending life that we've forgotten to talk about this other thing. So there's a lot of things that need to be filled in, gaps in knowledge and awareness and comfort just in having these conversations with your loved ones and families.
And that's so important to really highlight that the way that you sit with the patient and counsel them is such a holistic approach and a kind of 360 conversation with what's important to that person. And that can vary significantly from person to person, it sounds like.
Yes, and in a lot of ways, considering medical aid in dying, it's like your safety valve or your emergency ripcord, because people still want to keep on living, and most people are open to seeing what every day has to bring. And one of the in some ways it's ironic, but on the other hand, it's just really logical. When I have authorized someone, when they've met all the steps for medical aid in dying, then what they can do is they set that aside and they no longer wake up every day fearful for what the future might bring or what the very end might look like. And they can set those fears aside and keep on living every day to the fullest. And that's what we want for everybody.
If you had a visual, right, I think it's very powerful when you look at the data, and I'm sure Diana's personal experience would confirm this, that it's like a funnel that gets narrower to the bottom, right? So at the top, you have all the people that ask about MAiD, but a lot of them aren't really asking about MAiD. They're really just want to talk about planning end of life in general, right? And they're not really asking about MAiD in particular. And so only a subset of the people that really ask about it really end up deciding that that's the right option for them. And a lot of them don't even get a prescription. And then, as she just mentioned, a lot of the people that get a prescription don't ever ingest the prescription because they had it there kind of like insurance, right? Like fire insurance, just in case your house burns down. They're hoping they don't have to use it. And a fair number don't have to use it because their suffering never gets so intractable that they feel that they need to. But they were definitely still benefited by the comfort of knowing that it was there should they need it.
Yeah, absolutely. Just what Thad said is accurate, that many people inquire, a smaller number of people start the process, a smaller number of people actually complete the process, a smaller number of people get the prescription, and a smaller number of people actually use it. I am having an experience right now with an individual I am consulting with who is from out of state, who I have had two of the most amazing conversations and visits for her to make her two requests and for her to share with me her deep fears, not just about dying, but how she has interacted with the medical profession over many years. And she thought that she was going to be ready to move forward with ingestion, but I've just spoken to her recently, and she has told me that she feels so comforted and reassured by our conversations and so validated that what she's worried about and what she's hoping for are perfectly reasonable and right for her, that she's found a little bit more of a lease on life, and she is not ready to schedule a date. And that is perfectly fine. In fact, I consider it, I'm doing a really good job when I help people alleviate their fear, which is a kind of suffering, and I give them a reason and a comfort in continuing to live. And that's why I do this work, because it really is, it is about living. It's about life.
I think those kinds of stories are not shared enough. And thank you so much for sharing that, because more people need to hear that positive aspect about medical aid in dying. I'm wondering, Thad, maybe there's a legal perspective on this as well, but to really give people the permission to keep on living, and maybe they would exceed that 6-month kind of prognostic criteria. Does that weigh into the balance here? Is there something that maybe we're missing? Is there perhaps a way that state policy and law could step in and be more supportive of the patient? Is that 6-month criteria perhaps too restrictive?
Well, according to many, many patients, it's definitely too restrictive. So there are patients who have, I'll just use the phrase, grievous and irremediable suffering, who are not eligible for medical aid in dying in any U.S. jurisdiction. So patients who have progressive illnesses, so they see where the illness is heading, right, soon. The problem is it's not heading there it's not heading to death within 6 months. So dementia, I think, is one of the main examples that people bring up, advocates bring up, patient advocates bring up, because they don't want to live in late stage dementia, like stage 7 Alzheimer's or even stage 6 Alzheimer's and dementias like that. They basically are categorically, unless they have another terminal illness concurrent with the dementia, they're not eligible for medical aid in dying, because dementia has such a long timeline that in the early stages of dementia, when you still have decision-making capacity, you're not terminally ill. And in the late stages of dementia, when you're terminally ill, you don't have decision-making capacity. So you cannot satisfy the eligibility conditions, all of the eligibility conditions at the same point in time. So many people say that we should make MAiD accessible to dementia. And there's other examples of people who have, I guess, slower illnesses, but yet from the patient's perspective, they find their suffering to be intolerable, and they see MAiD as their preferred option to avoid the way in which they want to avoid that suffering, but they're not eligible. So that's the one. So I mentioned earlier, we've changed the types of clinicians who can participate in MAiD. We changed the waiting periods. We changed the residency requirements. We've changed a few other things. But the one thing that pretty much nobody from a legislative perspective has been touching is that 6-month prognosis. That's like a centerpiece of the law. But I think we will, in the next 5 to 10 years, that will increasingly come under the spotlight, as you suggested, which is that's not very patient friendly. And some states, because we're going state by state, right? And so some states will probably aim to enact legislation without a 6-month temporal limit, and they'll use like what basically every other country on earth uses, which is a condition of just suffering that's deemed to be intolerable from the patient's perspective, without a strict numerical temporal timeline.
There's a distinction between kind of acute terminal illnesses and kind of chronic terminal illnesses. So dementia would fit within that chronic terminal bucket, bucket meaning category, and something like metastatic triple negative breast cancer would qualify as an aggressive form of cancer with, would fit within that shortened prognostication of 6 months or less at a certain point. I'm just wondering, within that 6-month eligibility, it feels like, the timer is on, in a sense, that if someone qualifies for MAiD at that 6-month estimation point, what happens if, they're busy living their life and say, they are eligible, they're approved for MAiD, but they're still living, they're still, they're not ready to complete their life.
I'll take it a step. Well, two things. First, you added an extra adjective on terminal illness. I forgot you said something like immediate terminal illness versus
acute
chronic.
versus chronic.
Yeah. So I guess that's a fair point. I guess as a lawyer, when I use the word terminal illness, I'm thinking of it as it's defined in the Vermont statute and as it's used in the Medicare hospice regulations. So in those two places, it's the phrase is defined legally, right, as a irreversible and incurable illness that will cause death within 6 months. So, but you're right. In the common parlance, the phrase terminal illness is used far more broadly than that to other illnesses which aren't on a 6-month timeline. So there's a distinction between the legal use of terminal illness in the MAiD and hospice context and the use of terminal illness in the general population. To your question, a fair number of, to give you a real strict example, if almost every patient who gets medical aid in dying is on hospice, like 95% of them. Well, hospice has to continually reevaluate your eligibility for hospice. That's a legal requirement. They have to do it. So there are patients who get on hospice and their illness turns around, right? And the hospice medical director says, you know what? I don't think you're going to die in the next 6 months. And they are kicked off of hospice. So they actually did get better, or things didn't go as expected. And so that happens. And so that's great, right? So they actually have more life than they thought that they did. And they obviously definitely aren't going to take the MAiD. They have them, or at least the pharmacy has them, but those patients aren't going to take them. In fact, they have a problem because sometimes, this might get too technical, but sometimes people are worried about there's expiration dates on these medications. And so if you are lucky enough that your terminal illness ends up not being as terminal as was prognosticated, you may need to actually refill the prescription because the original dispensation of the drugs has gone beyond the valid date.
I'm thinking, just to give some clinical context here, because I think the word prognosis is really important to explore a little bit and help people understand that it is an educated estimate of how long someone might live. And by its very nature, it is inexact. And with the benefit of time, we get more information. And so there are tools that we have for certain diseases, whether it's dementia or heart failure or liver failure. There are standardized tools that give us some data, but there's also a range of patient experiences, right? So anytime I give somebody a prognosis, there still is a range of what's possible. I'm estimating based on solid clinical judgment, it could be 6 months. But the truth is, some of those people that I've given that prognosis to are actually going to die much quicker, and some of them are going to live longer. That's normal. That's okay. And that's a challenge for patients to live with. And truth be told, if you look at the data we have, doctors and other clinicians actually aren't very good about prognosis. And if anything, we overestimate how long people have to live. So our prognosis is too long. And that means we are not giving patients the benefit of the reality that their time could be short and time to prepare for it. But it's so difficult and challenging. And because sometimes physicians don't want to be wrong, they don't always engage in these honest conversations about what we know and about what is uncertain. And so it all comes back to having thorough conversations and really understanding what is happening with your body. I think Thad's example of someone, for example, who might go on hospice, I think the best example is probably someone who's had a stroke and they're deeply affected by the stroke. This family's values would perhaps be not to say pursue a feeding tube if the person is having some trouble swallowing, and they decide for that family they wouldn't want a feeding tube. So we think the patient is likely not to live 6 months, and if they're interested, we enroll them in hospice. Some of those people might actually clinically improve a little bit and their swallowing gets better and they're able to eat more than we thought they could eat safely. And suddenly it looks like they have longer to live. And so they graduate from hospice. And that's a success story. There's always going to be back and forth. It's not an exact science. On the other hand, modern cancer therapy has become so good that people are actually living with pretty advanced disease a lot longer. The problem is that when people then decline, the decline happens pretty quickly. And the typical person living with advanced cancer doesn't necessarily understand that or hasn't had honest conversations with their clinician about what may happen. And so they think they're going to just keep going on. And then when things start to change quickly, they are unprepared because they thought they had longer to live. So this idea about what do you think your prognosis is and really understanding what it means and what the uncertainty therein lies is so important, because here we are pontificating about these important concepts, but what we're talking about is real patients and real patients who are suffering, and it's all about what they want. The reason medical aid in dying exists is because patients across the country want it and demanded it. It wasn't an idea that doctors and lawyers came up with. Patients started telling us we want this as an option. So this is really all about listening to the patients, assessing and documenting their own particular values and offering whatever treatments are consistent with those values and being flexible because things change.
Can I circle back to, 'cause I think there's something that might be really important that we maybe, which is there's a 15-day waiting period, and maybe in Diana's practice this all works out very well. But my understanding is it's unlikely that you're going to be able to get the visits that you need from the attending and from the consulting physician in the minimum time frame that the law sets forth. Right, the law sets forth a minimum time frame and a minimum number of consults and approvals, but to get an appointment in any particular clinician's practice is a completely separate question. And so while theoretically you could have scheduled visit 1 and then on 15th or 16th day visit 2, but in the real world, where you call and you try to book that appointment, it might be separated by 30 days or much longer. So I'm wondering if that's a what's the way to say it? A cautionary tale, perhaps, that we should make for potential out-of-state patients seeking to go to Vermont or Oregon. That the time frame that you're going to need to spend, quote unquote, on the ground in Vermont may actually be much longer than 15 or 16 days.
Yes, unfortunately, and could be burdensome. The person who taught me the most about that issue was actually a legislator named Willem Jewett, who actually he was in the legislature when we passed this law. And then unfortunately, a few years later, he was diagnosed with a metastatic melanoma. And I had the opportunity to re-engage with him because he was interested in medical aid in dying. And when we talked about that waiting period, he looked at me and he was like, do people really not think that we have given this a great deal of thought and not appreciate just what goes through our minds as we're developing a plan that feels right for us? So I do believe that the time to carefully consider whether medical aid in dying is important, but this arbitrary 15-day waiting period for Vermonters and for people from out of state is in some ways an artificial barrier that experience now in other states is showing us isn't necessary. And again, things change, and I expect continued revisions to our law and to other laws in other states. And I also continue to advocate for people that live in Massachusetts and New York and New Hampshire to have this option closer to home, which is really what people want.
So let's talk about the ability to access MAiD. And I know Vermont is a mountainous state. It's a beautiful green, forested state. Lake Champlain is beautiful, and there's a great ferry that connects Burlington with Plattsburgh, New York. What are the practical implications of accessing MAiD in Vermont?
The biggest one is finding a willing prescriber. So you're talking about somebody who's traveling from out of state who doesn't have a connection to any medical providers in Vermont. And to find a physician who is willing to see you and to fit you into their busy schedule is a real challenge. And so what we are hoping is that people's medical providers closer to home, whether it's a neurologist who's caring for somebody with ALS or an oncologist caring for somebody with metastatic cancer, that a professional to professional referral would be what we would hope for. But it doesn't always happen because some providers out of state are not supportive and choose not to do that. But finding somebody who's willing to prescribe is a challenge, and there is a volume issue. So our state has about 650,000 people and medical providers to meet the needs of those people. There are many people from out of state who are desperate to have this as an option and wanting to come. And there's a big balancing act about how many people we can see and when. And then I am kind of toward the top 2/3 of the state. And I'm not on an interstate, and I may be a willing prescriber, but that person may have to traverse or travel a long way, where it might be more practical if they could see somebody in Bennington or Brattleboro if they're from Massachusetts or Connecticut, and it's a much shorter period of time. So we still have some work to do to help educate physicians and inform them about this practice and why it is patient-centered, and to encourage them to consider practicing this new procedure, just like we learn to prescribe new medications or do new procedures for other illnesses. And then, as I mentioned earlier, there are the logistics of finding a physical place to stay when you're making your requests and when you do your ingestion, and the coordinating of the hospice care, which we should be able to do relatively smoothly. But it is a lot of logistics. And it's a lot of planning and coordinating, again, at a time when unexpected things are happening and your energy level is low. So it really takes a big team of support in order to be able to help somebody.
I'm just curious in terms of finding a safe place to land for the patient coming from out of state. It seems almost like the residency requirement allowed them to kind of set up a temporary home. that they could, return to between doctor's visits for the 15-day waiting period. Are there challenges with out-of-state patients finding a safe place to land in terms of either between their visits or ingesting the medication?
Yes, I mean, I think we're encouraging people to be honest and upfront about the reason why they're coming to stay somewhere, especially for ingestion. And like many things in Vermont, there is a grassroots effort. And while there are some people who run an Airbnb who would not want this to happen on their term, there also are a number of people who say, I have an Airbnb and I'm supportive of that concept, and maybe I'm going to sign up to be a place that's welcoming of those individuals. And so we are working to try to identify locations in different parts of the state to make these options a bit more practical. And we're having some success. That's the positive, and it's still taking some time. That's the cautionary tale. And of course, there are some people out there who do not have the benefit of more time.
And I'm also curious about kind of the accessibility for people pursuing MAiD. So in terms of the practical realities of receiving the aid in dying medication. So they've come to you for their first evaluation. They've waited the 15 days. They've confirmed that waiting period with a second in-person visit. And then at a time of their choosing, they notify you, yes, whether by phone call or they stop by. What's next?
So again, small state, and given that the current formula that we're using that has been proven to have the best data for helping us achieve the desired result for a hastened death, we're using a compounded formula, not a regular, that comes from a compounding pharmacy, not a regular pharmacy. So we have one compounding pharmacy in Rutland that is very dedicated to the cause and that handles all of these prescriptions, and actually up to this point has been hand delivering those prescriptions for two reasons. Number one, to get the medication directly from the pharmacy into the hands of the people that need it. And also because this work is interdisciplinary and we need every team member to offer their own expertise. And so the pharmacist who's delivering the medicine also has an opportunity to go over instructions and to answer any questions from the patient. So it's a pretty unique situation that has been sustainable up to this point and may need to be altered a bit as we have more people. And again, more Vermonters as well as more people from out of state who are wanting this as an option.
When you say that the pharmacist delivers, does the pharmacist deliver the medications right after the prescription is written, or is it closer to the time that the patient plans to ingest it, right? Because those could be two very different points in time.
Yeah, that's actually, yeah, that's a good point. I would say a couple of things. First of all, it's the practice of many people who are prescribing for Vermonters first of all, if you make your request, but you're not going to use it right away, you do need to check in clinically. If you then decide to take the medicine, is your body in a good place to be able to accept the medicine? Are your symptoms well controlled? You don't have nausea, your bowels are working. So you need a clinical check-in before you take the medicine. And for many of us, that safeguard is, I'm not going to write the prescription until we know you're going to take it. It also eliminates other things like the medications just being out there when they may not be utilized, and expiration dates and all of those things. So I often wait. Sometimes what I will do is notify the pharmacy and send the prescription, but say, hold on to this. We don't need it delivered yet. I want you to just keep it on file so that all we need to do is make that last call in order for it to get delivered. So we do it a couple of different ways depending on the clinical situation. And I will say for the out-of-state residents, because we are a little bit more worried about people's understanding of the legality requiring that to be protected from the law, that all steps happen in Vermont. Our pharmacist is being reassured of his role in that particular process by knowing that the medications are delivered to a location when there is a hospice team and the patient is ready to take it. And we can have that level of confidence that somebody because people are desperate, and I really appreciate that. And I don't mean to be saying no to people who know what they want, but they really do need to use the medicine in Vermont. And so we have an obligation to take all steps to assure it's going to happen that way.
Can you reconcile something? Because on the one hand, I get that from a patient safety perspective, you want, if you're going to take the meds, you want to make sure that they're actually going to work. That you said you're not going to you might not write the prescription until they're ready. But then it seems, and I'm trying to reconcile that with what you said before, which is, oh, the patient has this comfort knowing that she has this option, ready. Well, now, if you haven't even written the prescription yet, there are at least two steps, right? When I'm ready, I think, okay, it's time. It's time for me. I want to take my MAiD medications now. I need to find you, get you to write the prescription, and I need to get the pharmacist to fill that prescription. So there's two contingencies that are left unfilled. And if I just think if it were me, I'd be a little bit nervous, like, oh, what if Dr. Barnard's on vacation? What if the pharmacist is, you know what I mean? I mean, as opposed to if I were able to check both of those off in advance, I wouldn't have those contingencies, and I know it's right there in my own bathroom. And I don't know how to balance
Yeah,
off. I guess
you know,
thought
I
about
hear
that.
you,
How do
and believe me, I am acutely. Those of us that prescribe are acutely aware, and we are in tight communication. I know my pharmacist very well. I call him. I look at my schedule when I'm going on vacation. Remember, the prescription contains opioids, and opioid prescriptions are only good for 30 days. And so, if I send the prescription and 30 days passes, I have to send another prescription. There are a lot of balancing act. And again, barriers and safeguards and what gives the patient comfort. I have qualified them for medical aid in dying. And if I have a relationship with an individual patient and I have assured them, you do qualify, it also is a little bit of a procedure. And so this is not medicine that is designed to be in your bedside table so that if you have one really bad day and you've just had it, you can just take it. There still needs to be some clinical thought and attention to, is this the right time? Are you able to take it? Do you still understand what you're doing? Can you ingest safely? And so it's a balancing act of what the patient wants and what we need to do to make sure that the process will be smooth and go well and there won't be any complications.
Sounds like a true art of medicine procedure.
Yeah.
I want to conclude with some key takeaways. And so I'm wondering for both of you, what are some ways that medical aid in dying in Vermont and other states might grow, change, improve in the next 1, 3, 5, 10 years?
Well, I'll just say two things. One, it's definitely going to become more available. There's only 11 jurisdictions right now, but around 20 or more states consider legislation every single year. So it's likely that, I think at the top of the list are Massachusetts, New York, Delaware, that's some more states will enact medical aid in dying. It will become more available to more Americans. And secondly, even if your state doesn't authorize medical aid in dying, as Diana suggested earlier, those residency requirements are unconstitutional. So that wasn't merely like a legislative policy decision, like the legislature of Vermont thought this isn't a good idea. They kind of had to remove the residency requirement. You can't limit things to your own residents unless you have a really, really good reason for doing it, and we don't. And so probably the New Jersey residency requirement will drop, and that's a major metropolitan area near Philadelphia and New York City and so forth. And so that will probably be the biggest expansion of medical aid in dying availability since California authorized it in 2016. So it's trending, right? We've never gone backwards. The availability has always moved in one direction. It's become more and more and more available, and that will continue.
Oh, I hope you're right, Thad. That's great. Sometimes things do go backwards.
As you said earlier, prognostication is not an exact science.
Yeah. And I would just add to that really I would For patients, I think it's about making sure that you have a practitioner who is listening to your concerns and is well aware of your wishes, both for living well and what happens when your disease gets to the final phases, and to not be afraid to talk and to explore and to have time. And because patients often have limited energy and don't have the ability to do so, I would encourage everybody who is interested to get involved politically, to let people know that this is just one of many things that you want as an option. And we all need to do our work to assure that the things that we're interested in, that our legislators and the people who are in control of making these laws are paying attention and moving forward with it. Because the patients who are sick and most in need, not everybody is a Linda Bluestein. You know, she is a particular individual who has spoken so passionately about her lived experience. I meet with many other people who carry that same passion, but do not have the energy to be here to say, listen to me and my needs. So all of us need to carry that.
Well, beautifully said, both of you. Thank you so much for joining me this evening. And thank you all so much for joining into our conference session today. This has been Lives in a Crossroad. Truly an honor to learn from you, Diana, and from you, Thad. So thank you both so much. And until next time, be well.
Great conversation. Thanks.
Thank you.